Everybody hear me? That better? I'm Kathy Dahlkemper. I'm the county executive from Erie County, Pennsylvania, and I'm honored to be the moderator today for this session, which I think you'll all find extremely informative. We have a great panel of experts here today who not only will be answering questions that I ask, but I think even more importantly, we'll be looking forward to your questions and answer the questions and take us in the direction that you want to learn more about from this great panel. I've been part of the opioid task force through NACo, and through that met many people, and we've talked a lot about the issue itself and the solutions and treatment and prevention of this epidemic, but there's so much more that each one of us has to learn and implement as we all try to fight what we know has become one of the biggest threats to our citizens in every county across this nation. So with that, I'm going to have each member of our panel introduce themselves, tell a little bit about themselves and the work that they do. And I want to start off with one of our own. We have Mark Polenkars from Erie County, New York. We are just neighbors down Lake Erie from each other. And so Mark, would you tell us a little bit about yourself?
Thank you, Kathy, and I want to commend you for the work that you do in Northwest Pennsylvania. We are the Erie County team here from Erie County, Pennsylvania and Erie County, New York, and one of the reasons we're a team is because we see the epidemic affecting the Great Lakes region, and it really doesn't matter what's on the dotted line regarding geographic borders. We all have to address them. As Kathy noted, I am the county executive of Erie County. That includes the city of Buffalo, 2 other cities and 25 towns, about 920,000 people. And we started to see the epidemic at the end of 2014, but really take hold in 2015. Folks, we are in a public health crisis, and truthfully the public health event of our lifetimes. You have to think of this like they did back in the late 1700s of trying to eradicate smallpox, or for that matter, what was done in the 1920s, 30s, and 40s to eliminate polio. It requires everyone's involvement to make it happen. And if there was any event that proves it more than any other, it's what happened last week in Miami-Dade County, in which a 10-year-old boy who was swimming at the public pool died of an overdose because somehow he became in contact with fentanyl, they think just from a towel that was left at the pool. He didn't come from a family that had an overdose. He certainly wasn't taking the drugs, but he overdosed and died, and that is an example of why this is a public health crisis. We need to work together as communities, regardless of what is on the geographic lines, to solve this, and that's why I was very proud to be a member and panelist, or not just a panelist here today, but a member of the National Task Force that NACo and the National League of Cities put together to address this issue. In Erie County, as I said, we started seeing this in 2015. 2014, we had 114 deaths as a result of heroin, other opiate-based drugs. 2015, it went up to 2,056. The beginning of 2016, if we continued on the trends that we were at, we would have had easily over 500 deaths. I declared a public health crisis in early 2016. I created our own task force working with people not just from Erie County but all over Western New York, and we were able to reduce the number of deaths such that at the end of 2016 we had exactly 300. It's 300 too many deaths, but it's probably 200 to 250 less deaths than we would have had if we hadn't implemented a number of policies that I know we'll be talking about, and policies and programs that are recommended as part of the national report. One final thing. If you focus solely on treatment, you're going to fail. One of the things that we're focusing on in Erie County, and is a major recommendation from the national report, is you need to focus on prevention. You don't want a revolving door policy where you're treating individuals, but then more people become addicted, and it just continues this endless cycle that unfortunately kills our constituents. This is the public health crisis of our time, and we need to band together, as counties have, to address this. That's why I've been traveling all over New York and the Northeast talking about this, and I know many other people have as well, because if we don't work together on this, we'll never be able to solve it. And I'm looking forward to the questions and comments, because I think we're all going to learn a lot today.
Thank you, Mark, and thank you for your leadership on this. Next, Dr. Dita Brose, here from the CDC. Please introduce yourself.
Thank you, Kathy. Hopefully you can hear me. As Kathy said, I'm an epidemiologist in the Division of HIV/AIDS Prevention at the CDC. I am an infectious disease epidemiologist by training, and I have dedicated the past about 15 years to HIV prevention among people who inject drugs. At CDC, as an activity lead for methods, I oversee the implementation of the National HIV Behavioral Surveillance System, which is conducted in 22 cities in the US. We've been doing this since 2002. And we're able to track HIV infection, risk behaviors, and access to services among 3 key populations at risk, including people who inject opioids and other drugs. I also serve as a subject matter expert for injection drug use, syringe services programs for my division, and I provide support for our division's effort to combat infectious disease consequences of the opioid epidemic. And in that role, in 2015, I joined the first CDC team who traveled to Indiana to help respond to the HIV outbreak in Scott County. And as many of you know, that county was dealing really with 3 overlapping epidemics. Epidemic of injection drug use, specifically a very powerful opioid, an epidemic of HIV, which you have all heard about, but also epidemic of hepatitis C. And so, as you might imagine, this was a very intense multi-agency public health response that required public health resources from all levels with the community support. And it, just with HIV infections alone, it will cost in direct medical cost over $100 million now. And so this was really a big wake-up call for all of us that explosive, large HIV epidemics can happen in this country, and that the decades of improvement and reductions in HIV that we've seen up until this point are threatened by the opioid epidemic. So I'm very happy to be here. Thank you for inviting CDC and to invite the perspective from an infectious disease epidemiologist, and I'm happy and honored to share our experiences here and to learn from you as well.
Thank you, Dr. Brose, and we're looking forward to your expertise as we continue this conversation. Next, I'd like to have Mr. David Royer, who's the CEO of Alcohol, Drug, and Mental Health Board of Franklin County, Ohio. So please introduce yourself,
Sure.
David.
Thank you. Good afternoon and welcome to Columbus. I can promise you our weather is not always this way, and so let me apologize on behalf of Franklin County for the weather you've experienced over the last couple of days. In Ohio, we have a structure that goes to address the issue of mental health care and addictions in somewhat of a unique way. We are a county board, part of county government, and our task is to bring together not only the funds that come in, state, local, and federal funds, but also to then assess and evaluate the need, develop strategies to address both mental health care as well as the issue of addictions, and then enter into the contracts for the provision of those services. We've been, I think, similar to your experience, we started to see an uptick probably in 14. Here in Franklin County, we're probably averaging, just in the city itself of Columbus, probably 10 to 12 overdoses a day. We're probably on track for about 500 deaths at the rate things seem to be occurring. The mayor and the county commissioners asked our office to put together a city-county strategy to address this issue, and I think you have that at your seats. I've been doing this for almost 40 years, being in the publicly financed behavioral health field, and what I can tell you is that a couple things. One is I've never experienced anything of this magnitude this fast. Throughout the process, you know, we've seen the methamphetamine, we've seen the crack, but this one is truly a baffling phenomenon. And I think that to that point, it really matters how we think about the problem in order then for us to be able to think about a comprehensive strategy. And I think with my colleagues, we share this view that it isn't just about treatment, it is about prevention, it is about education, but most importantly, we have to embrace it as a community issue. And we think that's a critical vehicle then for us to make progress, hopefully in near future.
Thank you, David.
Thank
Look
you.
forward to hearing from your experience here in Franklin County, and thank you for such a nice welcome for all of us. And lastly, Sue Thaw, Public Policy Consultant with the Community Anti-Drug Coalitions of America.
Well, good afternoon. I'm thrilled to be here, and CATCA represents 5,000 community coalitions across the country, about 700 of which are federal grantees from the Drug-Free Communities program. And I'm so happy to be sort of the cleanup speaker for the introductions, because we are the prevention people. We're the people that bring everybody in the community together to look at the data, to figure out exactly what's happening at the community level, and to figure out how to go upstream to figure out what needs to be done to stop the problems from happening in the first place. And so I think most of you know almost all of the money federally to deal with this issue has gone downstream to treatment, critically important, overdose reversal, and recovery support. But as everyone on the panel has already alluded to, unless we stop the pipeline and go upstream and figure out why people are falling into the river in the first place, we're not going to get anywhere. And so what we teach people is how to determine what are the exact community conditions that are causing the opioid epidemic in your community to start with. So obviously we're dragging people out of the river, but if you go upstream, in some communities there's no fence and that's why people are falling in. In other communities there's a hole in the fence, and in other communities people are driving too fast around a curve and they don't know how to stop. What we teach people to do is to actually come up with the community conditions in their community that are causing the problems, and then to come up with very comprehensive strategies across all community sectors. There are 12 of them, so youth, parents, schools, law enforcement, faith community, media, medical community, youth-serving organizations. It's a matter of not just getting everybody together to do what they think works, but to get everybody together based on an actual strategy, exactly what you talked about, that looks at how to solve the problem in your community using local resources, local talent. And we have some amazing outcomes and case studies on the table, where we have a resource table. And Chris, if you can raise your hand back there. We have examples of 3 counties in the epicenter of the opioid epidemic. So they started seeing these overdoses 10 to 12 years ago. And by getting the whole community together, doing the community assessment, doing a very comprehensive implementation around their specific problems, these places, and the 3 of them are Scioto County, which is very southern Ohio in Appalachia. We have a county in West Virginia, and also Carter County, Kentucky. So these were literally epicenter of the epidemic. Were able to reduce their initiation rates among youth from 5 times national averages down to much less than national averages by doing comprehensive prevention across all the sectors of the community. So we're thrilled to be here. Thank you.
And I love the hopefulness in the message that you are bringing forward, so we look forward to that also. So I'm going to start with a general question to all of you. We've been dealing with this across the country, some for years, some for a number of months. But what is always amazing to me is most elected officials will say, we're at the epicenter of this epidemic. So I send this out to all 4 of you. How do you see, from your perspective, and I know this has been evolving quickly, but how is this epidemic changing and how is it evolving from where we sit today? I would like to take that question first.
I'll start from our evidence in Erie County. It started primarily, as we note in the NACo NLC report, and we play a little name on it, a prescription for action, because it started with prescription drugs. Mm-hmm. And most of the people who were the primary addicts, and it is a disease, they have an addiction, came because they were legally prescribed drugs that they became addicted to. People at first were dying from overdosing on the drugs themselves. Last year we had individuals that died that ranged in age from 16 to 82 in Erie County, New York. And the older ones primarily died not from heroin, but from overdosing on high levels of drugs. What we're seeing now is fentanyl and all the fentanyl derivatives. And as you may know, fentanyl is an exceptionally deadly drug. It only takes a few grains to kill an individual. And it's becoming very, very difficult to address the issue because in New York State, we have a program called iStop, which limits the number of prescription drugs that a person can be legally prescribed. Those folks, when their method of drugs were cut off, then moved from prescription drugs. Instead of getting 4 different prescription scripts from a clinic, a dentist, a doctor, a hospital, now they can only get 1, and they need to feed their habit, so they move to heroin, which now, unfortunately, is being spiked with fentanyl. So the increase in the dramatic rise in deaths are people who've been addicted for some time, probably, at least what we're seeing in our community, but now because the potency of the drug is so strong, we're seeing this rapid increase in deaths. And for communities that didn't see the change early on, but are really starting to see it now, a lot of the deaths, you sort of missed the overdose deaths that were related directly with the prescription drugs, and you went straight to heroin and fentanyl. And that makes it much more difficult to try to resolve these issues because of the potency of the drug, the potency of the high, and how difficult it is to treat that. And then the other things that we're seeing, and you mentioned it, we're seeing a dramatic increase in hepatitis C, especially among individuals aged 16 to 30. That was not something we were talking about 2 years ago, but as the numbers are rising, what we're seeing is through the use of the intravenous drug use and the sharing of syringes, we're seeing increases in hepatitis C. There was the outbreak in Indiana with HIV. So you need to think about safe syringe exchange programs or syringe drop-off locations, because if you don't, this is not just an issue with addiction. Now it becomes an issue, as you noted, the doctor noted, with regards to HIV, hepatitis C, and it becomes so expensive to treat that. I know in Erie County, because we're self-insured, we have 2 people that are suffering from hepatitis C, and just each of the treatments is over $100,000 a piece. So how did they get hepatitis C? I don't know as county executive. Maybe they had a drug problem. Maybe it was a different way. But if I see this dramatic increase with chronic hepatitis C among individuals starting in age 16 to 30, when it used to be hepatitis C was a baby boomer problem, that scares me because of the cost of treatment alone is going to be substantial to address those individuals. And for a lot of communities, and I've been going around New York State and other areas talking about this, hepatitis C, HIV is not even on their radar, and it needs to be, because if people are using heroin and fentanyl through intravenous drug use, you have increased rise in hepatitis C and possibly HIV in your communities, and a lot of people aren't even thinking about it.
Anyone else see some changes in evolving of this epidemic?
I think the biggest thing we see is, again, every indicator is trending the wrong way, but not only is it trending the wrong way, it's the speed to which it's trending the wrong way. Obviously, the fentanyl issue has been huge in the last 6 months to a year. We know Hep C's up. The overdoses don't seem to be abating on the streets our EMS and paramedics are faced with. But the one thing that it has been positive, at least here I can speak to, is that the community is coalescing, and it's just not government, it's the education system, it's private business. And we're coalescing around this idea that it's a community issue, it's a community strategy, it's a community solution, and I think that's the one positive that I've seen.
Yeah, I just want to echo that. So in the places where this was a problem 10 years ago that have gotten on top of it, they knew it was a problem because they were seeing overdoses and fentanyl overdoses 10, 12 years ago before anybody had even heard about it. And so what they knew was they had to decrease access and availability and change social norms in these communities. And they did it with scale and scope by doing everything from closing pill mills. I don't know how many of you are dealing with the pill mill problem, but they got law enforcement involved to actually close the pill mills. In Appalachia, where there's a culture of sharing, there was a media campaign called Forget Everything Your Mother Told You About Sharing that got out with scale and scope to everybody. People changed local ordinances. So in a few of these places, any home that was built or bathroom that was redone had to have locked medicine cabinets. So I could go on and on, but the places now, especially in West Virginia, Their overdose problem has markedly decreased. Even in Scioto County, their overdose problem has markedly decreased. And part of it is they got on top of access availability and they changed social norms. So it can be done, and it's not that no one's dying, it's just the places that have seen this for a while, that have really organized the way you're organizing now, have actually seen a difference. I think there really is hope.
Thank you, and I can provide a national perspective on that basically echoes everything that you've just heard. So just as an anchor point, we have now over 300,000 overdose deaths in the past 15 years and 33,000 in just 1 year due to opioid overdose. So it is, again, as everyone said, a crisis. But we are seeing some changes, and we are seeing sort of 3 distinct overlapping epidemics in overdose. So the first, as was mentioned, the first wave of increase in overdose was due to commonly prescribed prescription opioids, and that's likely due to the increases in overprescribing. And we've seen a 4-fold increase since 1999 till about 2011. The good story is that it seems to start to level off. We haven't seen nationally large decreases yet, but in some jurisdictions we have seen those. The second sort of driving force in overdose death has been heroin. And as prescription opioid overdose deaths was increasing during that same time, heroin was somewhat stable or increasing slightly. But since about 2010, it skyrocketed, and we've seen another 4-fold increase in overdose deaths due to heroin. And then in 2013, we saw the same thing with fentanyl. So clearly at the national level too, we see this pattern of prescription opioid use starting this trend to heroin, to fentanyl. And as was mentioned, fentanyl is about 100 times more potent than morphine. And carfentanil, as some of you have experienced, is even more powerful. It's used for large animals like elephants. And so again, it takes very little to do a lot of damage. Now, along those trends, to bring it back to the infectious disease, we're seeing huge increases in hepatitis C nationally. Between 2010 to 2015, we've seen an increase of 290% in acute new infections. And over 60% of those are due to injection drug use. So there has been increase in injection drug use in parallel to the increases we've seen in overdose deaths. And then, of course, we had the outbreak in Scott County, Indiana, that puts HIV on the map again. And so once there are risky injection practices and HIV enters those networks, it could spread very fast. And so access to certain services programs was mentioned, and we might talk about it more later, but I want to mention that this same comprehensive integrated community-based program that was initially designed for HIV might also work really well for hepatitis C, other bacterial infections like endocarditis, which is an infection of the heart and could be very deadly, but also could be a very important route for overdose prevention, because naloxone distribution and education about other prevention methods of overdose are really well distributed through certain services programs. They're very good at reaching the hidden population that might not come out, that might not see a physician, that might not turn up anywhere else. These are the programs that could reach them.
Well, while we're on that subject, what are the components of an effective program for those of us in county government, and what kind of resources might be available to us through the CDC?
Sure. So as mentioned, certain services programs are community-based, ideally comprehensive and integrated programs. And I just want to mention that these are not new programs. We've had them in this country for nearly 30 years. And so we have 30 years of data and experience that show us that they're very effective and they're cost-effective in preventing HIV and other infections, and in linking people to addiction treatment. And we know that from the research we've done that they do not increase crime or drug use in the communities they serve. In fact, there are many benefits to the communities they serve. And so, as I said, ideally they're comprehensive programs. They're most effective when you combine sterile syringe access, risk reduction education, and safe disposal of used syringes with services like HIV testing. For example, we know that most of the infections happen from people who are not aware of their status, and they're not in treatment, and so their viral loads are high and they're more infectious. So getting people tested, linking them to treatment, and providing other supportive services to help them stay in treatment is key. Hepatitis C testing and linkage to care. We now have a cure, and hepatitis C, as we've talked about, is common, more common than you might think. It's deadly, but we have a cure, and there's a change. You know, in CDC, we're now starting to talk about elimination, which wasn't possible before. So that's including those linkage to those services in a syringe exchange program is key. Other services include linking to substance abuse treatment program, including medication-assisted programs. We know that when medication-assisted program is combined with certain services program, we see the highest reductions. Overdose prevention, as I mentioned, naloxone distribution, and many programs include other key services like linkage to prenatal care, vaccinations, social services, employment opportunities, food, clothing, all these immediate needs. So these really are comprehensive community-based programs. I'd like to mention two more things. One is that they are one other key component of effective program is peer-to-peer driven interventions. This means that some people will come to the syringe exchange program, but some will not because they cannot physically come due to structural issues like transportation, or they cannot because of stigma and other issues. And so peer-to-peer education is key in getting these services and information and linking them to services through their peers. And we've talked about primary prevention, and I want to mention these programs as an opportunity for those as well. So these programs serve people who already inject drugs, but we know that most people get introduced to injection drug use by another person who already injects drugs. And so changing those norms around initiating people to injection could be key to prevention. There have been studies that have shown that people with education, they will reduce, they won't inject in front of others who are not already injecting, and they will discourage others from injecting with proper education. These programs could be a vehicle for primary prevention as well.
Thank you. Mark, I wanted to kind of go back to your declaring a public health emergency, and what did that allow you to do in your county that you might not have been able to do without that proclamation?
Well, in New York State, county executives have a lot of power, but it was probably the first time that any county executive had declared a public health crisis as a result of what really is a man-made epidemic, not something in the past that would have been your normal expectation. It set a tone, is what it did. And public leaders need to set the tone. They have to be in front of this, leading the community, because if you're not, who else is going to do it? And by declaring a public health crisis, it sent a message. Our local media was like, we know there's a problem, but we didn't know it was that bad. And there was a lot of pushback from some people saying, well, if you're saying a public health crisis, people are going to think it's bad in your community. And I go, that's why I'm declaring it. It is bad in the community. But it's bad everywhere. And I can look out at this audience and I see representatives from across the region, and I see a couple others that served on our national task force, Greg Puckett from West Virginia, Gary Moore was our co-chair from Kentucky. And when we talked to others, whether it was from Arizona, Washington, and the like, everyone was in the same boat. So if you're sort of ignoring the problem and the crisis, you're doing a disservice to your constituents. And what it does is it gives you also the power to act. Now, when I did that, I empaneled our Commissioner of Health and our Commissioner of Mental Health to co-chair a task force in which we brought everybody in, people from the treatment community, people from the health community, people from law enforcement. And we said, we all need to work together and come up with many ideas to solve this problem. I think of it as how FDR, when he took office in 1933 to address the Great Depression, he didn't come up with just one or two ideas. He threw everything at the wall and saw what stuck. Some things will work, some won't. Try new things. But if you just try one or two things, you're going to fail. So that's why you have to focus on the prevention. You have to focus on the treatment. You have to focus on naloxone, Narcan. We've trained more than 12,000 residents of our community, not just first responders, but teachers, priests, pastors, you name it. Anybody who wants a training will go, and we'll provide the individuals at the training 2 free doses of naloxone. And we know it works because there were 2,000 saves in the city of Buffalo alone just from Buffalo first responders in 2016. I had 300 people die in 2016. We had 2,000 saves in the city of Buffalo alone. Granted, maybe some of those were duplicates, even triplicates. So if they're triplicates, that's 600 other lives we saved. But the naloxone is a tourniquet. It saves the person from dying. It saves them from bleeding out, but you have to have everything else in place. The medicated-assisted treatment, the other types of programs to work to help that individual overcome their treatment, and then the issues on the prevention and education, and that's where declaring the public health crisis made a big difference, because it really allowed us to work with the providers in our community to address the prevention, to keep people from being prevented in the first place, to work with our educators. Our hospital groups, we have 3 major hospital groups in Erie County, City of Buffalo. They never work with each other on anything. But we were able to bring them into the room and say, we're going to work on a proper prescribing protocol for anybody who comes into your emergency room. So now, regardless of which one of the hospitals you go to, and there's 3 different major groups, you're going to get treated the same when you walk into an emergency room. Our medical society, when they don't, I'm the worst kind of person to them. Not only am I a politician, but I'm a lawyer. The doctors don't like me. Simple as that. And they certainly don't want me telling them what to do. So we went with the medical society, their local AMA. And my health commissioner led a discussion saying, we have a public health crisis here. We need to work on proper prescribing guidelines. So before it was even changed at the state level, we worked and we had our local medical society come together and have proper prescribing guidelines for opiates and then send it out to the doctors. If I hadn't declared a public health crisis, I don't think they would have done it. So you have to take the lead. It allows you to set the tone. And then the response is, yeah, I'm the elected official. I'm an attorney by trade. Let the experts tell me what to do. I set the tone, but let the experts tell me what to do and let them run with it. Because I can be the spokesperson for the community, but I shouldn't be the one telling the community what to do. Let the experts on the Opioid Task Force tell people what to do, and we'll help get that message out. And if I hadn't declared a public health crisis, I don't think that message would have resonated as much as it did.
Thank you. David, I know you have as you said, we all have your report here, your Franklin County plan, and you're working closely with the city on that. One of the things in there, you talked about having partnerships with business leaders, which you know, Mark talked a lot about the partnerships we all think of normally, but tell us a little bit more about that.
It was actually it was an interesting process. We interviewed in about a 3-week period. It was a very compressed time period, but we interviewed over 100 some individuals that interface with this. And one of the things that struck us was that a couple things. One is every one of those organizations, over 60 some organizations, have employees, and employees have families. The other thing is that we started talking to our corporate partners here in Columbus. Some of our largest employers stood up and said, you know, we need to get involved. The federal and state and local resources can be generally targeted towards certain initiatives, but tell us how we can be of support. We actually now have been bringing our corporations together through a lot of the larger corporations and said, let us create a fund at our Columbus Foundation where we can donate money for a community education and prevention program. We believe that we have to better educate, and it goes to this idea of upstream. We have to better educate our employees. When we educate our employees, we hope that we're also then teaching them simple things like proper medication disposal. It's amazing to me how many folks don't understand how often and how you should go about disposing of medicines. So they're interested in that. They're interested in donating their talent as well as their funds towards a broad-based media campaign. I think at the end of the day, whenever we employ a person, we actually employ their family. And when their family is touched by this, it devastates them, but it also then it affects the economic productivity. The economic costs of this to a community, whether it's in our healthcare community, government, private sector, is pronounced. And it's important that I believe that you reach out to that corporate community and ask them, actively solicit their support and say, you know, we are all in this together. This is a community issue. And I think it can play not only a funder, but we have some of the largest corporations here in the city that are willing to produce materials that then we can go through the chamber and distribute those materials down to medium and small employers that may not have the resources to educate their workforce about the issues surrounding this crisis.
So this is the big issue right now is opioids. And as you look at prevention strategies, is it helpful to just focus specifically on the opioids, or is a strategy of a broader perspective something we should be looking at?
We need to do both. And the reason we need to do both is that most kids do not initiate with opioids, they initiate with alcohol and marijuana. And we need prevention infrastructures that basically deal with the initiation. So what we're trying to do in prevention is stop initiation or delay the age of onset. The earlier somebody starts to use, the more likely they are to end up with a lifelong addictive disorder. And if you can put off till 21, when somebody starts using, their chances go down to almost zero. People who start using before the age of 15, their chances of having a lifelong addictive disorder go up 3 to 4 times. So we need to do basic prevention of all substances to delay onset, but we actually need to do things about the opioid epidemic itself, because it is what's killing people, it's what's getting attention. So what we just got, I don't know how many of you know about the Comprehensive Addiction and Recovery Act, CARA, which was passed in the Congress last year. There actually is a provision in it to give enhancement grants to drug-free communities coalitions so that they can continue to do their alcohol, tobacco, marijuana, and other prevention while doing more with more intensity around the opioid problem, because we do have to get on top of the opioid problem, because people think because opioids are a medication that was originally prescribed by a physician that somehow they're safe. People don't understand the problems with taking other people's medications. People don't understand, and this is where I think prevention becomes really, really critical. If you're going to look at access and availability, and I'm going to give you an example that sort of takes it from the top, you're going to do your media campaign to talk about lock your meds, give your meds back to take back programs, don't share your meds. Okay, but if there's too much availability in the community, then that's much harder than if you can reduce it. So we had instances of people where they would go after someone had died in a nursing home, and they looked at those people's unused drugs as their, quote, inheritance. Okay, well, that's insane. So they had to actually change the policies in the community so that those drugs are not the property of the family. They actually were then destroyed. So you have to sort of take it across everything. And I think I maybe had talked before about people going into open houses for realtors, and people who are already addicted will go to an open house and go through all the medicine cabinets and take the opioids. So you have to get realtors involved. All of a sudden you're getting unlikely partners involved in the community level who need to understand what's going on. So if you're selling a home, you need to either have locked medicine cabinets or take all of the stuff out of the house when you have an open house. So does that sound like prevention? Most people think of prevention as a 5th or 7th grade prevention program. Yet what prevention really is reducing access and availability, changing social norms so that you can actually change population level behavior to be able to reduce initiation across the board in your community. So thank you for asking the question.
We'd like to invite anyone in the audience who has questions to, we have 2 mics on either side, and you're more than welcome to come up, and I'll try to go from mic to mic and address your question, have the panel address your questions. So it looks like we have some questions here on the right. Please tell us your name and what county you're from first.
My name is Bill Hullum. I'm Commissioner from Arapahoe County, Colorado. We've been working on this problem for the last 5 years, and it's been a long, arduous task. We have accomplished a lot. We have convinced our sheriff and most of the municipal police departments to have drug take-back programs. We coordinate with the DEA, and they have their annual one. We're averaging 30 pounds of drugs a week take-back just in our sheriff's department alone. And you're absolutely right. I think one of the key issues is to get the drugs out of the homes. And I know personal friends who I told about the program who they have opioids in their medicine cabinet for 5 and 10 years. Maybe something will happen, they need it, but that's important. The other issue is Narcan. We've trained all our first responders carry Narcan, and when our drug-addicted prisoners leave finish their sentences, they're given a Narcan packet and trained as to how to use it. My question is, first of all, I'm so pleased that NACo has taken this as a major issue in the country. I also would like to ask, basically, from the panel, we have seen kind of a somewhat of a drop in deaths, but I don't think we measure effectively the number of overdoses. And how would you recommend getting the hospitals and the medical community, the doctors that are involved, that really care about this issue, to report the overdoses? And finally, we've found our coroner, when we have a death, and we were averaging about 8 deaths a week. It's down to about 3 now, but we're seeing the spike in the heroin. And what we've found, our coroner has found, is she'll call the doctor who was prescribing the opioids to the patient who died. Some of the doctors will just hang up the phone. And we need to have a better opportunity to educate our physicians that they're part of the problem, and we're not there to be vindictive about it. We're asking them to really change the prescription policies.
So I think one of the things that was in our report, the prescription for action, was this data issue, and it seems that it's a problem across the country. So I don't know if anyone on the panel could address that and how we can actually gather better data within our counties to be utilized for making good decisions. That's basically your question, right?
Well, one of the problems that we realized, as Kathy just noted, is there is this discrepancy in the data. We saw the data that was going to the CDC, and we looked at it from our own counties and said those numbers are wrong. And what we also were finding out is if you have a medical examiner in a county, your data is much more likely to be accurate than if you have a coroner. It's not that the coroners were necessarily doing it on purpose, but some of them, they might know the family. They may actually be the funeral director that's actually showing the body as well, and they would list it not as an overdose death, but they would list it as a death associated with unknown causes, heart attack, stroke, even though there was no evidence of that. So what you really have to do is at least as officials, is put pressure on those that are actively involved in dealing with the overdose deaths to ensure there is accurate reporting, to ensure that your state's getting accurate numbers. We finally sort of, in New York, we've got a lot of regulations, but we're finally ensuring that the data that goes to the New York State Department of Health, which eventually goes to the CDC, is accurate where we didn't think it was, especially in the more rural communities, where the numbers weren't just, they were wrong. We know they were wrong, and everybody in those communities knew they were wrong, but they just couldn't prove it. So it is important. It's important that doctors have a role. That's why we, in our community, brought the Doctors Association in. Because if I, as the county executive, the elected official, once again happens to be the attorney, tell the doctors what to do, they're going to go say, go fly a kite. But if our health commissioner, working with their medical society, their local AMA, comes up with proper prescribing protocols and what should be done, they're more apt to follow that. We know it works. I have a Medicaid Inspector General's office in my county. I can look at every Medicaid case in Erie County. I can't release the individual data, I can release aggregate data. For 7 years in a row, the #1 prescribed drug in Erie County for Medicaid patients was hydrocodone OxyContin. It's now, after 2 years of education and prevention, finally dropped down to number 5. And when I talk to the private insurers, they don't give me, they say, well, we can't release our exact data, but your numbers don't surprise us. So in all likelihood, the number 1 prescribed drug among private and public insurance was hydrocodone OxyContin. We've reduced that because of the education component that we've had working with the doctors. And you need to bring in those associations. Some of them are going to hang up. But if you can get 95% of them to agree, yeah, that's correct, you're going to see a drop in the number of prescriptions that are originally provided, which means you're going to see less people addicted. So you really have to work with the medical society, at least as we've seen in our community.
I've got another question here.
Leads actually right into where I was going to go as far as the medical profession. Years ago, when they, from what I understand, when they had wholesalers that were given conditions, okay, you can sell so many pills. I'm from Pasco County, Florida. My name's Jack Mariano, County Commissioner. We had a pill mill epidemic. People flying from Kentucky all over, going in there. We work with our sheriffs, we work with the Attorney General to finally shut them down. But why do we allow these prescription drugs to be prescribed over and over again? They're the heart of the problem. You don't hear many times about marijuana overdoses. I think we need to focus on the heart of the matter. From what I understand, and you can check this out, but a local attorney firm from my area is going to partner with a company, I think it's Motley Rice. I think they were involved with the BPO spill. Mm-hmm. They're going after this wholesaler. When they first started, they had 3 conditions as far as like putting out the sales. They've had to look and monitor what the sales were. Then if they found a spike of like 80%, they had to stop it. And then if it went further, they had to like come back and put the plan in. The first 3 parts of those things, they were never followed. I don't have all the details, but it's pretty much a conversation I had right before I started to come up here. So looking at that, diving at that, especially as an attorney, I think you should really go take a look at that. Legally, did they do this? Did they do a violation? And if so, collectively, NACo should be jumping on that and shutting this down that way and penalizing those people, because instead of worried about governmental programs, governmental funding, let's go make the medical people pay for what they've done to what people.
So I know some counties have actually started down that track, and I know Mark is leading one county that has. I think it was earlier this year that you did file a lawsuit. Is that correct?
We filed a lawsuit against 11 prescription drug manufacturers and 4 doctors who were basically paid promoters that go around the country and promote the drug as a safe alternative for pain management. They basically were paid shills, is the best way to put it. Because the average doctor would hear from them and say, oh, okay, this makes sense. Purdue Pharmaceuticals saying this is a wonder drug for pain and there's no after effects, there's no addictive measures. Well, we know they're highly addictive and they can kill on their own. There are people that die just from hydrocodone OxyContin overdoses. So we filed suit against 11 manufacturers, 4 of the doctors that were basically these paid advertisers, so to speak. Because I look at it as the drug dealers, they don't care who their clients are. They want to sell their drug. They don't care where they are and where they live. They'll go across dotted lines. It's no different than the pharmaceutical manufacturers. They wanted to sell their drugs to individuals, and they lied to the public, and they lied to the medical profession about what these drugs were capable of doing. And they know it. We've hired a firm, a different firm than you've referenced, that was involved in a major lawsuit against Purdue Pharmaceutical. And they have data from Purdue that proves that Purdue knew years before that these drugs were highly addictive and could kill. But they were still advertising it as a safe alternative for pain management. So I'm looking at it, this lawsuit is just one tool in our tool belt. We need to save lives through prevention and treatment facilities. This is something to recover costs for the county in the long run and to hold them responsible, but it can't be the only thing. Just like we can't arrest our way out of their problem. That was the issue. Now we know that this is an addiction issue that needs to be resolved, unlike the crack epidemic, which was treated as a law enforcement issue. Commissioner Johnson from DeKalb County noted that earlier. This is an addiction issue. You have to have a law enforcement component, you have to have a treatment component, you have to have an education component. Everyone has a role, and there is a role for the attorneys as well to hold those responsible. I look at the drug companies that push this knowing it was bad, just as bad as the drug dealers selling it on the corner. They knew they were going to kill people, yet they still advertised it as a safe alternative for pain management. I look at the local doctor who heard the data that was provided to them and made the prescriptions as they were just doing what they were told. So I'm not necessarily holding them responsible. But for those who created the epidemic, whether it's the pharmaceutical companies or, in your issue, the wholesalers, which is less of a problem in New York, that is someone and parties that need to be held responsible. It's as simple as that. I said, this is the public health crisis of our time. We need to do everything possible to address it, and in my view, one of them is going after those who created it.
So I want to talk a little bit about treatment. And David, I know Franklin County has approved a addiction stabilization center. Can you tell us a little bit about that and what you hope that will achieve?
When we were out talking to folks, I mean, the number one thing we heard was, and we did focus groups with EMS, police, emergency room physicians, is that there was a growing sense of frustration that after we Narcan an individual, we take them to the emergency room, there was no place for them to go. It was back out on the street, and they were going to cycle again, or at least a risk of cycle. And we repeatedly heard this through the process. The other thing that I don't know if it's happened in your community, but in about the last month, I've noticed in the media that there's been a change in the conversation to how many Narcans should a person receive? How many times should a person get Narcan? Which to us here, it started to really beg the question, why aren't we doing something different about after the overdose incident when there is hopefully a moment of opportunity? And so what we've done is we're in the process of converting. We have an old community hospital on the south side that had an emergency room. Working with EMS, what we're doing is essentially diverting anybody who does not have a medical complication, diverting them to the center where they are then triaged in the emergency room. If appropriate, they go up into the detox unit. We're expanding. We already have 30, 40 detox beds. We're going to expand another 20. But the idea is that we're going to then have a step-down process so that when an overdose victim comes in, that they're offered the opportunity to immediately receive services and supports, detoxification and medication-assisted treatment. And we're in the process of incentivizing our providers to immediately take them into treatment when they come out of this stabilization center. And we will pay them a bonus. So not only do we reimburse them for the treatment, but we want to incentivize them to take them on first day opportunity when they are being released from the stabilization center. So that hopefully, we know the longer we engage people in treatment and care, the greater the chances are that we're going to decrease the risk of Hep C, IV drug use, et cetera. So it really came out of this conversation. It was very concerning to me that we were starting to ask this question of how many does a person deserve? And I kept thinking to myself, would we ever ask how many EpiPens a person deserves before we should let that person die instead of administering an EpiPen? But we needed a creative solution, what we believe is a creative solution that offers immediate opportunity when that person has come back from a near-death experience to get engaged in the treatment process.
Did you have a question? Thank you, David.
I did. J.P. Ducrow, Ashtabula County in Ohio. And is there any movement being made at the national level with legislators about modifying the sort of the reimbursement policies or the rating policies for medical facilities? Because I know a part of the problem has to be this complete intolerance of pain, or the belief that we have to mitigate pain and being punished if somebody even says they're in pain, whether they are or are not. We don't really have a way to know that other than what they say. And for people that are drug seeking, it's awful hard to hold a facility, a doctor, a hospital accountable when they know that what they suggest to help that patient, their livelihood may depend on it. So I don't know if there's any progress being made in that field.
Yeah, there is a little bit. So Hal Rogers from Kentucky and a couple of other members last year looked at the fact that the patient satisfaction surveys that you're given your reimbursement based on how satisfied people are, with pain being added as the 10th vital sign when people claimed they weren't satisfied because their pain wasn't being taken care of. What they're trying to do is not get rid of asking about pain, because we do have to be careful about treating people who are in pain. It's a legitimate thing, but that it's not tied so closely to the reimbursement for the facility based on how people rate you on that specific one. So yes, people in Washington are definitely looking at it, because you're right, it's a really big problem.
Dita, you have something to add?
I would just add from the CDC guidelines side, we have published CDC guidelines for opioid prescribing for non-cancer or non-end-of-care pain. And so these guidelines are meant to assist physicians to make the correct decisions about the amount of prescription opioids and how long the prescription opioids, what supply should be provided, because we know that people who walk away with a longer supply, 30 days or more, are more likely to develop dependence. And so those guidelines are encouraged. We don't have legislation to force those guidelines, but we're encouraged. We have seen the latest numbers on prescribing rates have come out and been published just recently, and we are seeing a decrease more recently. It's still very high. Prescribing is still at 3 times the levels we had in 1999 and 4 times the levels that Europe is currently experiencing in terms of prescribing rates. So we still have a way to go, but there is some optimism.
Just quickly, you can make a difference in this. Massachusetts was the first. They actually passed standards limiting the amount of prescriptions that will be provided to a first-time recipient of opiates. In New York, we passed it approximately 6 months later. If you're under the age of 18, you can't get more than 3 days for the first prescription. If everyone else, it's 7 days. We know if people followed that treatment, they're probably not going to get addicted to the drug. It's usually after 2 weeks where you start getting addicted. We did that in New York, so did Massachusetts, and I know other states are looking at it, and you can be vocal in that to your state policymakers that we need to make this change. It's pretty much based on the CDC guidelines, but the CDC can't do it for the whole country. But each state can do it, and that will make a big difference, because once again, you want to stop that revolving door. The less people who become addicted, then it'll be faster to get out of this. It took us 15 years to get in this crisis. It's going to take us at least 10 to get out of it. But if we still have that revolving door, it's going to continue, and we could be talking about this 25 years from now.
Here we have another question.
I must admit that I'm kind of a Johnny-come-lately to this particular problem. It was about 2 years ago that my medical examiner that I approached me and said, Mayor, we're seeing a significant increase in heroin OD and deaths. And then that really started my curiosity in this area. Mark, I want to thank you for your help in the last few weeks in some of our discussions to bring me up to date. One of the things that has become very apparent to me is that there's probably no more crying need at the local level than what we're talking about today. Yet there's also no more crying, compelling need for states to be more engaged. And I think you've talked a little bit about that, Mark, in your comments. But are you finding difficulty in getting the states engaged? Because it's the states that, in many of our states, it's the state government that really controls the health care system. As overrides a health care system, the county health departments are subsidiary to the state. But are we getting the level of cooperation at the state level that we should expect? And if not, why?
Well, Kathy was part of the task force. If you have not read this, read it. Take a couple copies. Give one to your health commissioner. They're back there. Basically, it's a best practices guideline, and there's a whole section in here, Mayor, about what the states need to do. We're responding to the crisis. We're the ones that are the primary treaters of the crisis. But the states play a huge role in offering, usually they control the number of beds that are available for treatment. They control funding sources. We basically went to our governor with a number of other county leaders in New York State saying, we have to fix this. And I'm proud to say that my health commissioner, along with a health commissioner from another county, basically wrote the law that was passed last year in New York State, changing prescribing guidelines, offering more treatment, getting more money. Not as much as we'd like, but a little more money. And it also sent a message that this is not just a regional issue. It is a statewide issue, and as we all know, it's a national issue. The states may not be the ones that are out there with their employees applying the naloxone. They're not the individuals that, in all likelihood, unless they have a state hospital, that are going and applying the treatment, whether it's a methadone clinic, an inpatient treatment facility. But they have to be engaged. And if you just call your state health commissioner, they're going to know about it. But you need to talk to your governor. You need to talk to your state senators or state assemblymen, however they're called, and they need to know about it. Because if they're not hearing it from you, as the local official, as this is one of the most important things that's going on in my community right now, it's not going to be on their radar. And I can tell you, I pestered Governor Andrew Cuomo a lot until he finally said, okay. And he sent the lieutenant governor around on a listening tour, and she came back saying, we need to do this. And then he was proudly signing a law into effect all across New York State, which actually has had a positive difference, especially on the prescribing guidelines. So states have a role, but you got to pester them, because as an elected official, I did not run to be the county executive to deal with the opiate epidemic. When I ran and won my county executive race in 2011, the word opiate and epidemic was never mentioned once. But you have to learn it, and so you got to push the state officials, I think, the same way, because unless they're hearing it from you, and they're hearing it a lot, they're not going to act. Mm-hmm. There is a role, and as this report says, it's a big role, but you got to push them.
Yeah, I mean, I'll just agree from Pennsylvania's standpoint. And, you know, where Erie County, PA sits, right next door to us is Ohio, and right next door is New York. So whatever they're doing affects our state, and I'm sure many of you have the same issues. You're close to another state. And so there is that border that's people don't think about, but we have to deal with different states and where they're at. And in Pennsylvania, we were one of the last to go to prescription drug monitoring, and still today it isn't very good in terms of talking to the systems in Ohio and in New York and in other states that border Pennsylvania. So that's a problem, but they're fixing that, and we have to continue, I think, to beat the drum as local elected officials. And I know you wanted to add a little bit to this conversation too, didn't you?
Just a little bit from the federal perspective. You know, at CDC we provide guidelines and best practices, but sometimes things don't really change until the local leaders actually demand those changes and advocate for resources. And I just wanted to echo what was said earlier, but also give an example in Scott County, Indiana. You know, before the HIV outbreak, certain services programs were prohibited from the state, and there were no legal programs. And, you know, CDC recommended them and others, but it really wasn't until a local, the county sheriff, a highly respected leader in the community, talked to then Governor Pence and said, what I need is syringes. We're at that point, and it's getting out of hand, and this is what we need. And I think that was the critical message that changed the governor's mind and ended up supporting certain services programs in Scott County in Indiana. So I just wanted to echo how important local leaders are in advocating for change.
David, do you want to say anything about Ohio and what you're seeing?
Yeah, it's very interesting. Our legislature, the governor just signed the budget, the biennium budget, and the legislature really they stepped forward and expanded funding. And the strategy that was used was that the state associations, whether it was the State Association of Judges, State Association of Treatment Providers, they formed a statewide coalition, and they undertook a really comprehensive education program. And I think that moved them to understand that they needed to support the issue, they needed to invest in funding. And I think it ended up being probably around $180 million over 2 years, which is unprecedented. There's always seems to be a reliance, an over-reliance in my view, of the use of Medicaid, to which, you know, obviously for an expansion state, it's been a wonderful thing. But the state also said, you know, we're not making the kind of dent that we need to, and I give the legislature great credit for recognizing that.
Yeah, I have one other point. Chris and I went to meet with Senator Claire McCaskill's office, and as you probably know, Missouri is the only state that does not have a prescription drug monitoring program. However, county by county in the state, they're trying to get them set up so that when in fact the state has one, it won't be so hard to get it moving because the counties themselves are actually instituting them on a county by county basis, and I think they're getting there. So I think counties and cities are incredibly important in leading the way.
So we'll take one last question here before I have everyone kind of wrap up. Thank you.
I'm Teresa Daniel from Dallas County, Texas, and we've been involved in the drug war for many, many years, and this is something else. I mean, we're obviously keeping, you know, as much attuned as we're able to. One of the tools that everybody uses is looking for the data to see, okay, you know, how much, where very specifically. And I noticed that there was on our chairs, there was a map of the United States that has green dots and pink squares on it. And I'm just kind of curious because it doesn't seem to match up real well. Is there any explanation on why that is?
Yes, there is.
Okay.
So thank you for mentioning that. I was wondering if I'll get to explain that map. So right after the HIV outbreak in Scott County, we were asked, is my community vulnerable to a similar outbreak? And so at the CDC, we looked at what data was available nationally and developed a mathematical model to try to estimate where vulnerable counties might be based on hepatitis C and other injection indicators, risky injection indicators. And so that's where this map came from. The pink dots are counties that were found vulnerable. There are 220 of them. Now, there was a major limitation in this analysis, and that's that we were limited to data that was available to us nationally. And so we've published in detail our methods for developing this mathematical model, and we're encouraging state and local health departments to use their own data, which might be more recent, more detailed. You may have additional data that we did not have at the national level to look at that. So just because your county is not on this map doesn't mean that you're vulnerable. And so that's a key point we wanted to make, and there are resources to help with looking at that data and assessing your own vulnerability for such outbreaks. And the green dots are current search services programs as of the end of 2015, I think. And just one thing I wanted to point out about that is sort of the striking mismatch between where search services programs are and where we think the vulnerability is. And so that's where the push to expand those programs to really help in the communities, at least in those that were identified. So did that help a little?
Yeah, it does. It sounds like we still have a lot of work as far as trying to match up formulas, trying to match up availability of data. And I know we're always attempting to improve accuracy and just a whole myriad of things. But I just thought it was interesting. I thought, boy, we got to do a little bit better on matching up things.
Yeah, and this is vulnerability for an HIV outbreak.
Right. No, I understand.
No, absolutely, and you know your communities best, and often it could just be talking to your local program directors and walking the streets and talking to people who are using, and so
Thank you.
it takes a lot.
So we want to give everyone time for the exhibit, but I want to allow each of our great panelists to wrap up if there's anything that you didn't get to say that you're dying to tell everyone before we get off of the stage. I don't know, David?
Yeah, you know, one of the things that I think is important for us to remember is that not every opiate dependent person is essentially comes from the same place. And one of the nuances that we're trying to sort out, and actually maybe it's more of a question than it is a comment, is that we find that there are pockets of multi-generational use. And then we also find that there are what we call first-generation users. And one of the things that we have to nuance, I believe, is to better understand the strategies, both from a community education perspective and a prevention perspective, about how does one intervene within a multi-generational environment versus a first-generation user. A lot of times people think that all the first-generational users tend to be in your more wealthy suburbs of your community, but that's not necessarily always true, and that's a misnomer. The other thing that I would offer is to remember that in your urban communities, the people of color have been experiencing this problem for many, many, many years. And it's important that we recognize that the strategies that we use to try to work inside communities of color may be fundamentally different than how we go about it on a broad-based. And so I guess what I would ask you is to make sure that you nuance those strategies to reflect the reality and the composition of your community.
Yeah, I just want to say that CATGA provides technical assistance and training in building these multi-sector community coalitions, and that counties actually are eligible applicants for the Drug-Free Communities Program, which is the federal program of grants to communities for up to $125,000 a year for 5 years to be able to build multi-sector infrastructure. And Greg Puckett is going to man our table because we have our own conference actually that we have to get to in Atlanta. But we're happy to help, and I think we have a lot of wisdom and experience to share for those who are looking to build sort of the front-end prevention part of this continuum.
Thank you. Deidre?
I would just add that I'm very hopeful. I think we've heard a lot of devastating numbers here today, but I'm hopeful because we have the tools. We just need to figure out the models to implement them, and just hearing from this panel and others about innovative ideas on how to work with the public health sector and law enforcement and faith-based organizations and schools and all these partners and the community coming together. It's just amazing, and it gives me hope that we will overcome this. And as an example, in Scott County, Indiana, again, the community came together and made a huge difference, and they have stopped one of the largest epidemics we've had. And so, again, this encourages me, and I'm hoping that those lessons learned will be applicable elsewhere as well. Thanks.
First off, I just want to thank you for coming, because as public officials, we have to lead, and you need to educate yourself. And I didn't know anything about this subject 2.5 years ago, and now I know more than I ever wanted to. So you have to lead, and to do that, you have to educate yourself, and to lead on issues that you might not necessarily thought you would. I didn't run a few years ago to be the county executive who would be advocating methadone clinics in communities. Never thought I would, but I do now, because I understand the benefit of medicated assisted treatment, which also includes buprenorphine and Suboxone, which could be applied in doctors' offices. So you need to learn about all the alternatives out there and not be afraid to advocate for them. I'm a politician. I pulled this. The public is not going to hurt you from it. They're going to realize you're actually trying to solve a legitimate issue in the community. And we were doing this, and then my pollster said, you should poll this to see if it's good. I said, well, go ahead, do it. And we found out the public thought it was a brilliant idea, because they thought I was leading on an issue that mattered. So my political folks are really happy then. But you got to do it regardless, because if you don't, you're doing a disservice to the public. So it's nice to know that the public can see that you're leading on a tough issue, and if you don't do that, you're going to do a disservice, because you're going to have a lot of your constituents die who don't need to.
Okay, I said we're going to wrap it up, but we have one last person who seems to.
Very much. Is it on?
Tell us your name and where you're from.
I'm the judge executive of Round County, Kentucky, and we've just initiated a needle exchange program at my behest and my encouragement, and we've had it's about 4 months, and we've had some success. We had a doctor come and wants to put a methadone clinic, and I can't get my magistrate to even talk about it. So you said you've decided, how do you talk them into it? We've got a Suboxone clinic in my community. It's been there before I became judge. But we did move forward on the needle exchange. But the methadone clinic, I'm having a tough time selling it. I think you need to hit every aspect of it. because it's a major disease, major problem right now. But how do you sell it to your magistrates or your council members?
Go tour a good clinic. We did that in Kentucky. I've done that in Western New York. Go tour a good clinic. Bring them with you and show them what the clinic actually is, where it's not just going in there and getting the drug, it's also treatment and counseling. Then they'll see it. And also, it's also finding out who's addicted. They probably think, and they still probably have in the back of their mind, oh, they're heroin junkies. In my community, the 43-year-old daughter of a retired state Supreme Court justice overdosed and died after coming back from a treatment facility. In Binghamton, the Binghamton police chief's son died recently. You also have to sort of put a face on who's addicted. And it's not the heroin junkies as they think in their mind. It's probably the neighbor next door. And get them to the clinic and see what it actually looks like, even if you have to travel 200 miles to see what one looks like, and find out and open their eyes as to what the problem is, who the problem is part of, and then let them see what one of the solutions can be, because it's not what people think it is.
There's a methadone clinic in Lexington, Kentucky, and I think there's one up in Huntington, West Virginia, about 60 miles either direction. And what they're telling us is they think it'll attract more criminals to the area. That's been the argument against it. So, yeah.
We're putting a methadone clinic in one of the highest urban suburban areas of my community, literally a mile down from where the Buffalo Bills football stadium is, in a very affluent community. And why is it going there? Because that's where part of the problem is, and the community leaders realize, hey, this isn't attracting crime, it's actually solving a problem. It just takes education, as I've seen it. It didn't happen easy, but we educated the community leaders, and they realize it's needed, and it's not going to do the bad things that they think it is.
Thank you.
So I want to thank everybody for being with us today. I want to thank NACo for taking a leadership role on this, and I would really suggest that you grab extra copies of the prescription for action, give them to those in your community who still maybe don't see the gravity of the situation. And again, thank you to our great panel. Wonderful.